Hello, I'm Dr. Barbara Bruce. I'm a clinical health psychologist, and I am very excited to be able to talk with you about an area of interest for me, which is pain. And we're going to talk at this time about acute and chronic pain. I want to talk about the problem of chronic pain in the pediatric population and the impact of that pain on the individual, the family, society, and the healthcare system. Then I want to talk about pain rehabilitation, both the structure of pain rehabilitation and options for treatment for adolescents with chronic pain. And I want to go through a case example of a pain patient that we were able to publish and also show you a video of a mock intake assessment for a fibromyalgia patient. And last, review the efficacy supporting pain rehabilitation in the treatment of chronic pain in both adolescents and adults. I wanted to show you the fibromyalgia treatment team at the Mayo Clinic. I'm going to introduce myself. Here's a picture of myself and my team for the fibromyalgia program. I am a clinical health psychologist, and I'm boarded by the Board of Clinical Health Psychology. I have been working in the field of pain management my entire career and have served as the clinical director of the Mayo Clinic Pain Rehabilitation Center program, as well as developed and served as the clinical director of the Pediatric Pain Rehabilitation program at the Mayo Clinic. I then came to the Mayo Clinic in Jacksonville about a year and a half ago and was recruited to build a fibromyalgia treatment program, very much an interdisciplinary team using cognitive behavioral strategies to help patients be able to cope with their pain and improve their quality of life and functioning. Here we have Dr. Obril and Rivera, our medical directors. Dr. Obril is the chair of rheumatology at the Mayo Clinic in Jacksonville. Dr. Rivera is an internist, and both of them with significant interest and experience in the management of fibromyalgia. Jeff Sheffield is our administrator who helps us get all of the paperwork done. Myself and I work with two nurses who provide care both in the medical clinic as well as teaching with me in the cognitive behavioral program. So what is pain? The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. You can see some images here to the right of pills and people who look as if their head and their back are hurting. You can see some of the emotional distress in that young girl's eye as she is describing a pain experience. And then we also get a feeling for the emotional distress that can be related to pain, such as I can't keep pretending that I'm okay. Some of that personal distress. At the top is a pain measurement scale. And we ask patients to tell us, how does your pain feel? This is really a scale for children because it has beautiful faces in it of no hurt at all to the worst pain ever or imaginable. And we ask adults the same thing. Please tell me how you rate your pain today from 0 to 10, with no pain to worst pain ever. Pain's a subjective phenomena, and so it needs to be rated by the individual. We can't take an x-ray. We don't know how a person is feeling unless they tell us. What about acute versus chronic pain? Acute pain really is designed to help us avoid danger. It's a survival mechanism, and as can be seen in the 16th century drawing, it used to be thought of as that you put your foot near the fire, put your hand near the fire, and the pain sensation goes from your hand or your foot straight up to your brain in an ascending, bottom-up information. We now know that there is descending modulation, top-down as well as ascending, just like in your chapter that talks about this. And we know that there are multiple factors that influence our experience of pain. Everything from prior experiences, our attention and expectation given the setting, our mood, anxiety and depression, neurochemical and structural changes, genetics, and peripheral and central sensitization. include these pictures. They are from artists who are experiencing chronic pain and place our artwork on the American Pain Society website. I bring this to your attention to show you that it is a sensation. It is also an emotional experience, and people struggle with pain, very human factor to chronic pain. Pain's an unpleasant sensation. It can range from mild to severe. It can be episodic or continuous. It can be mildly inconvenient or totally incapacitating. We define chronic pain generally as pain that persists for over 3 months or over 6 months, and the varying definitions are usually by length of time, but we also define chronic pain as pain that persists longer than expected for an injury to heal. It can result from trauma, it can result from injury. Chronic pain can result from an infection or an inflammation. It can result from an illness or a chronic disease. It can result from an exacerbation of a pre-existing painful condition. We can have chronic pain that results from a medical procedure or a surgery, or sometimes no cause is identified, such as with our fibromyalgia patients. How you feel acute pain. Generally, acute pain, there is a pain source in the periphery or in terms of the internal structures. There's an electrical impulse that moves through nerves to the spinal cord. The nerves in the spinal cord release chemicals that either amplify or subdue pain messages and are sent on to the brain to interpret the sensation as pain. What about chronic pain? There may be a chronic condition that's causing the pain. There may be a known injury with sustained difficulty causing the chronic pain, such as nerve damage, or the cause may be unknown. Nerves sometimes misfire and send the wrong message. We often say that chronic pain is like a doorbell that's been stuck on. There are possible chemical imbalances that affect the pain response, and as we showed in the last slide, the brain interprets the message as pain. When we prick our finger and there's a normal response to pain, the sensations go to our spinal cord and up to our brain to different places in which the painful sensation is experienced. We prick our finger and there are imbalanced neurochemicals, goes to our spinal cord, and now the sensation can be amplified to those areas of the brain. And what happens over time? The sensations are actually amplified even further. In our brains, we know that neurons fire and they synapse with one another. Repeated signals can create memory pathways in our brain. And that's where chronic pain can start to generate additional sensations over the time. The Institute of Medicine report from the Committee on Advancing Pain, Research, Care, and Education in 2011 reported that chronic pain affects 116 million Americans today. Other studies have shown that chronic pain affects more Americans than diabetes, heart disease, and cancer combined. And here you can see the estimated number of people with diabetes, heart attack, angina, stroke, and cancer. What about children and adolescents? There was a systematic review of 185 studies in 2011 by a researcher named King. They looked at these studies that were conducted worldwide, and they came up with the following prevalence rates of chronic headache, chronic abdominal pain, chronic back pain, musculoskeletal pain, multiple sites of pain, and other pains. And you can see how broad these ranges are. It is estimated that the rate of chronic pain in children is similar to that for adults, with 11 to 38% of children experiencing chronic pain and 5 to 10% 5 to 10% of them being significantly debilitated by their pain. We also know that the perception of pain is highly individual and complex. Differences in pain can be considered by breaking it down within a bio-psychosocial model. Here you see that the cerebral cortex is involved in noting the quality, the location, the type, and the intensity of pain. The sensory cortex is essential to the perception of pain, and neural influences transmit, modulate sensory input along the pain pathway. Psychological responses to pain-related stimuli affect our perception of pain, as well as cultural responses to pain-related stimuli. There are psychological factors that influence the perception of pain, and they are many. We may consider pain from a bioecological model. And these factors include attention, expectation, anticipation, appraisal, catastrophizing, cultural factors, learning history, models for coping with pain, how did parents manage pain or other significant people in a person's environment, situational demand characteristics, perceived control over pain, the presence of anxiety or depression, anger, and sleep disruption. An example that I use often to teach patients about the perception of pain is a story that we all hear of a person in combat who is severely injured and yet remains in combat, helping colleagues, comrades to safety. The soldier doesn't even realize that he or she has been severely injured until they're brought to a place of safety and the crisis has passed. And then the pain seems to be felt. That really takes in a number of these factors that influence our perception of pain, which includes appraisal of the situation. Safety is more important than pain. It may be the expectation, anticipation. I need to get people to safety. I can't be attending to this at this time. There may be models for coping with pain in which that soldier had seen others be very heroic in managing a painful situation, the situational demand characteristics, etc. Pain impacts an individual in all aspects of their life, from emotional response to family distress to physical debilitation, exposure to medications, social milieu that is upset and impacted by pain. There can be medical complications from treatment. There certainly can be financial impact, whether a person has lost their work, workers' comp, lawsuits, changes in financial situation that adds further stress, person unable to work or go to school. And from a behavioral standpoint, people can become very dependent, unable to function independently, and experience much emotional distress. How about for children? Here's another picture that's from the American Pain Society website of a child drawing a picture of themselves with severe face pain. When we look at the impact of pediatric chronic pain, we really look at the behavior. Children, adolescents, young adults with chronic pain can become much more dependent, immature, demanding, and angry. Families are changed and distressed that can impact this behavior. From an emotional standpoint, patients we see are depressed. They become despondent. They can even become hopeless or suicidal. There can be sleep disturbance from pain, anxiety, and isolation. As I mentioned, families are often very distressed when there is a child in pain. Parents are distressed, but also siblings, and family structure starts to change. Family doesn't eat together any longer because the child who is sick is unable to come to the table. The family doesn't go to church any longer because they are unable to go as a family because of the sick child, and the impact goes on and on. From a physical standpoint, we see children that are very debilitated. They are not moving very much because of their pain, and they're often becoming weak and deconditioned. They might be in a wheelchair in order to ambulate. They may use a cane or even be completely bedridden. I'll talk about a case example in a few moments of a child who ended up spending essentially all of her time in bed due to pain and the deconditioning that followed. From a medication standpoint, we know that children are exposed to opioids just like adults are. There are many controversies right now in the use of opioids in the treatment of chronic, what we call benign pain, because we're really talking about pain here that is not from cancer or end-of-life disease. In one of our studies, we found that only 15 to 25% of children were taking opioids or narcotics on a daily basis, but over 82% of those children had been exposed to opioids as they've doctored for their chronic pain. From a social standpoint, children lose friends, they lose their social activities, their clubs, and their contact with peers. Often peers move on without them because they're unable to keep up in terms of physical activity or physical endurance, and the kids are not in school. From a medical complication standpoint, anytime a patient is exposed to multiple providers, multiple specialists, lots of evaluation, there comes interventions that can have significant complications aside from the medication exposure, and I'll talk about that in this single case study that I'll present to you in a few moments. Financially, it's estimated that $19.5 billion in healthcare costs are spent annually for children with chronic pain. There is another significant cost to families when parents have to stay home with sick children, whether it's hours missed from work or actually having to stop their job to care for a sick child. So there's cost to the family, there's cost to society with medications, office visits, hospitalizations, and parental work absences. From a school standpoint, this is a dramatic impact. Children are missing school. Their school attendance is disrupted, their academic performance is disrupted, their credits for graduating from high school are disrupted. Their biggest fear is that they won't be able to go on to college and ever have a career. And in fact, it is one of the most significant stressors that children face, is how they could ever repair what I call the bomb that went off in their transcript as they missed upwards to 2 or 3 years of school trying to feel better. So the cycle of chronic pain and fatigue, we look here on this chart at behavior. We look at emotions and family response. And we start in the beginning. Illness, injury, fears, concerns. People offer support. Oh my goodness, stay in bed. Let me get this for you. Patients decrease their activity. They're trying to decrease their pain and fatigue. They're hoping and trusting in the medical system that their illness or their injury or their pain will be relieved. People help them with daily tasks. There's increased attentiveness. Everything is circling around this patient in efforts to help them feel better. As they seek more and more medical attention without easy answers, there's a sense of loss of control. But the family continues to do more and caretake for this patient. When there is increased activity, pain, and fatigue, there's often increase in symptoms with anger and frustration. Patients attempt to reestablish their roles. They struggle to do so. They find that they are losing strength and endurance and deconditioning. They feel guilty. They're withdrawn from the family. They try to do it all. They overinvest, and then they end up paying for it. There is often self-limiting behavior. I don't want to do it because I'll have to pay for it. There is anxiety. There's fear about pain and fear about the future, sadness and irritability. And the family begins to disengage because they don't see the patient getting better. There is withdrawal and isolation by the patient, decreased self-esteem, and the family is feeling discouraged and withdraws further. This is when the pain and fatigue is in control. Just to show you an example of a case study. It's a case example, And it's a good example of a case study which was explained in Chapter 2 in your book on research methods. This case example is written up for publication to provide physicians a good example of a pain patient who was over-medicated and not being helped with appropriate therapy. And the title of this paper that was written with, hopefully is now Dr. Sang, who was a medical student at the time, and my colleagues in the pain rehabilitation program, Pain Relief is a Primary Treatment Goal. At what point does functioning and well-being become more important? A case study of an adolescent with debilitating chronic pain. I'd like to introduce you to Andrea, which is not her real name. She was 15 years of age when she was referred to the Pediatric Pain Rehabilitation Program. She came to us with bilateral pain in her upper and lower extremities. She also had severe facial pain and had been in severe pain for 22 months, almost 2 years. She had been an active, healthy teenager, and she got a soccer injury to her left second toe that began this phenomenon of chronic pain. When she came to us, she held diagnoses which included complex regional pain syndrome, which we often see in teenagers following a sports injury. She also was diagnosed with Raynaud's phenomena and erythromelalgia. She had had extensive physical therapy. She'd had extensive exposure to medications. She had a lumbar spinal cord stimulator placed as well as a cervical spinal cord stimulator, both of those being very, very invasive, expensive interventions to try to manage her pain. I want you to take a look at Andrea's medications on admission to our program. She was on 3 different opioids, and as you saw in your chapter, there are issues related to the use of these medications and lots of controversy about its use in chronic benign pain. And for this young lady, she was on 3 different medications. She was also on 2 medications that have been FDA approved for fibromyalgia. One is an antidepressant, Cymbalta, and one is an anticonvulsant, Lyrica. Topamax is also another anticonvulsant that is used often for headache pain. She's on a muscle relaxer and other medications. She was on 3 different sleeping medications. You see here Restoril, Trazodone, and Ambien, which doesn't make a lot of sense to me, but that was what had been prescribed, and a number of other things to try to help her. B12 injections, Zofran for nausea, etc. When she came into our program on admission, she had not been in school for 2 years. I should say 22 months, almost 2 years. She was completely bedridden at the time of her admission. She came in a wheelchair. She was completely dependent on her mother as a primary caregiver, and her mom had had to stop her job to care for her daughter full time. She was having severe bowel and bladder symptoms and inability to get up out of bed to go and use the restroom. She was very depressed when we saw her with suicidal thoughts. The CESD is the Center for Epidemiological Studies of Depression measure. Her score was over 40, which is significantly elevated, suggesting clinical depression. At the end of a 3-week pain rehabilitation program that I'm going to tell you more about in a moment, we were able to help Andrea wear her shoes and socks. That was through significant desensitization and work with physical and occupational therapy. She was able to ambulate independently. Remember, she had not really been able to put her foot down or wear a shoe or sock since this injury started. She was able to complete her self-cares independently. She showed dramatic improvement in anxiety, depression, psychological distress across all those measures. We had withdrawn all of those opioids successfully over the 3-week program, which is a goal for all patients who come into the Pediatric Pain Rehabilitation Program at the Mayo Clinic. The goal is to slowly withdraw those medications while the patients are learning other strategies for coping with pain. Most of her benzodiazepines had been discontinued over the 3-week program, but they are more difficult to withdraw, and some of those medications were still being tapered in a longer taper schedule upon her discharge from the program. We were able to turn her neurostimulators off for increasing lengths of time while she was in the program. When we contacted her a year after the program, she had asked to have both of them surgically removed, and they had been removed. So at 1-year follow-up, this young lady was still in school full-time, where she'd returned after our program, and now she was playing volleyball and back to her active self. Quite a success story.